Good morning, Dr. Patino here at the Cosmetic Surgical Center of Costa Rica. We're starting microair power assisted liposuction to the suprapubic area. This is, I don't know if you can see, this is the hair, airing pubic area. The vagina is right there, and this is the hair. And what's coming out, Wendy?
Oh, I see that beautiful yellow fat. Show me.
Yeah, and so that's what we do. And we do it very slowly. We waited probably a good hour before we started, right, Gabby?
Right. There it is.
And beautiful yellow fat that's coming out, but we do it slowly, right? That's the key to do these. Look at that, very nice fat. Thank you. So this is microair power assisted. You see how the cannula is vibrating, the tip of the cannula? It's like a toothbrush. It's like an electric toothbrush, right? It vibrates. So much like a toothbrush, you don't have to go at it, with full force, This is very gentle, although some surgeons, and I would say the great majority of surgeons that I've seen do this procedure, they go at it. And so it's more trauma to the tissue. See how gentle I am? Very, very, soft. And this lady had liposuction before, but look at the output, right? It's very clear fat. Gabby, why don't you show them the output so they can see what's coming out. When we do this, it's consistently this way. I told patients yesterday and the day before, don't even look at my past surgeries. Look at what we're doing the next day, right? Because we know it's going to be like this, right? Because it's consistent. Consistent, beautiful output like this. We can get it every time. And that's because of the special technique that we have here. It's a special type of anesthesia, tumescent anesthesia, but you have to tumescent properly. So this is no secret. Every doctor that does this procedure knows, but they don't use the right amount of anesthesia usually, and normally they don't let it sit for a while. We let this sit for an hour, right? So the epinephrine takes effect only in 15 minutes, so theoretically all you needed to do is wait 15 minutes and start. And I've seen doctors start at 5 minutes and they don't do quite as much of the tumescent, they don't tumescent all planes, and of course the output is very bloody. Thank you. Alright, so the patient is on her side, the buttocks are over here, and this is the waist. We're giving her some really nice waist, and basically we're pretty much toward the end of the procedure. And notice how even toward the end of the procedure that aspirate remains completely bloodless. What color is that, Emily, you think?
It is yellow.
Yellow fat, man. That's what we like. But my strokes are very slow and also very well calculated. So that also decreases the risk of internal organ perforation. We've never done that, thanks to God, but we go slow. It's like driving a car. If you go very fast, you can go into an unintended area and crash, right? Here, the same thing. When those things happen, it usually happens to a surgeon that's been doing surgery all day. Maybe he's on his 10th surgery of the day on a Friday afternoon or something. They're very tired and they go at full speed. And then they go into an unintended area. Thank you. So I'm ambidextrous, so you can also use the non-dominant hand. This is my non-dominant hand in this case, but I am ambidextrous. But even if you are not, most surgeons are ambidextrous, but if you are not, because you go so slow, you can do this very safely, right? And look at and I'm doing the lower back area. Look at the aspirate, completely bloodless. So in order to obtain that bloodless aspirate, the patient does not take any aspirin-like medications or heparin or blood thinners, and the surgeon does not give any aspirin-like medications, heparin, or blood thinners. Commonly, surgeons do give aspirin, and they do give aspirin-like medications, and they do give enoxaparin, which is a blood thinner similar to heparin, right? So enoxaparin, and that's accepted care, right? In order to prevent a blood clot. We don't do that, and the reason why we do surgery differently, and our patients are pretty much pain-free. Their pain level is usually 0 to 2, so they ambulate they walk immediately in the operating room after we take the compression boots off. And early ambulation is what prevents a blood clot, right? And that way you can get this beautiful aspirate, right? Without any bleeding. If you give enoxaparin and aspirin, you know what? That's not gonna be bloodless. The patient is gonna lose 1 or 2 cups of blood. That's the usual. If you don't wait, if you do right away, if you don't use the plenty of tumescent anesthesia, you just do like a little bit, or if you don't put the epinephrine, and if you don't put the lidocaine, then some surgeons do this. Yeah, so it's important. All those things are important, right? So you have to do the proper amount of anesthesia. You have to wait before you start. That's probably the most difficult thing for surgeons. They don't want to wait, and you want to go to the next case. So you might think it's ridiculous for me to wait an hour before we start, but that's what it takes. And the longer we wait, the better for the patient. The much less bleeding there is. Thank you. Alright, so this is the other side of the patient. She's on her side, and this is Microaire. You see how the tip vibrates. Microaire power assisted liposuction. It's a power tool similar to a toothbrush, right? So when you have the old toothbrush, you go very hard at it, and guess what? There is bleeding, gum bleeding, right? But when you do the electric toothbrush, you let the toothbrush do its work, and then there is no bleeding. This is very similar, you know, but also the type of cannulas that we use. There's a lot of things that go into getting a bloodless aspirate, right? But we already talked about the patient, what the patient can do. Don't take any aspirin-like medications, no vitamins, no ibuprofen, no Motrin, no aspirin or aspirin-like medications, no herbs of any kind, some herbs. We give a patient a big list of things not to take, right? So if they have pain, they can take Tylenol. That's what we recommend for 2 weeks before and 2 weeks after surgery. The surgeon doesn't give any blood thinners of any kind, and surgeon does plenty of the tumescent anesthesia. Each bag of anesthesia has 1 milligram of epinephrine to clamp down the blood vessels, and we wait an hour to start. That hour allows for the fluid that was infiltrated to come out. So the tumescent anesthesia, the tumescent fluid needs to be tumescent, and it takes about an hour for that to happen. But in addition to that, we noticed that, for example, this is the last hour area that we're doing it, and look at that output, right? It's incredible, right? So the longer you wait, we, in personal experience, we have noticed that the longer you wait, because the epinephrine starts acting, you know, after 15 minutes or so. But I believe that the action of the tumescent anesthesia, probably the volume that's infiltrated, something about it makes it so that it is bloodless like this. But I believe that the most important thing, besides the tumescent properly in all planes, because if you tumescent in one area but not in another, then there is going to be bleeding. So if you do this, you tumescent properly and you do it slowly. I compare this to basically having a bullet, right? You have a bullet in one arm, in one hand. You push that bullet, or you may even throw it into your other hand, right? Nothing's going to happen. But if you put that bullet on a pistol, and you shot that pistol, right? Then there is going to be a bullet at high speed creating significant damage and injury and bleeding, right? So here we're not causing any bleeding for a variety of reasons, but probably one of the most important reasons is that we're not using a very aggressive cannula. We're going slow, and the patient is tumescent in all areas, and we can do this predictably in pretty much most cases, right? And also, not only that, but if we're going to do a fat transfer to the buttocks, which we're not doing in this case, right? This is what's going to go into her buttocks, not red, not pink, So our fat graft retention, in other words, whatever fat we put into the buttocks stays there permanently, right? Because we're not putting blood. It just makes sense. If whatever you see the surgeon putting into the buttocks is red, well, guess what? That's blood mixed with fat or fat mixed with blood, and obviously the blood is going to get reabsorbed. In addition, it's irritating to the tissues. It could create a collection of blood. It's a hematoma, more risk of infection. Usually, if that is not really pure fat like that, the trauma from the cannula can break the fat cells and oil is released, and so then they can have oil cysts. And I even believe that probably the blowout fractures that you see when you do fat transfer to the buttocks are a foreign body type-like reaction where the body kind of rejects that blood that's outside the blood vessels. It's outside where it's supposed to be and pushes it out, much like you would push out a bullet or a piece of glass that's inside your body. The body usually forms a scar, pushes that out into the surface, and that could be one of the etiologies of the famous blowout fractures. And I understand that it's a destruction of the anatomy that usually causes that problem. It's a problem that we never have and we never want to have, but we are extremely careful when we do fat transfer to the buttocks. We do it also under ultrasound guidance, and we're teaching other doctors through the World Association of Gluteal Surgeons. We have over 35 countries of the very, very best surgeons in the world. We're teaching courses on ultrasound to keep this procedure safe. Look at that aspect. Incredible. Thank you. And look how comfortable I am. I'm not sweating it, right? I'm not going at it and sweating it. So it also saves energy on the surgeon. It limits the risk of injury to the surgeon as well. So it limits the risk of injury to the patient first, right? That's the priority. And why is that? Because look at my strokes. They're so well calculated. They're so slow. There's nothing out of control here. This is all very controlled surgery, right? And so, but I'm also not sweating. I'm not going at it at full speed like, you know, most surgeons do, right? And at the same time, it saves time, you know, because you may think, oh, this is going to take forever. No, we are extremely efficient, and the reason why is because we don't have to process that fat when we put it into the buttocks. We don't have to process with any system whatsoever. We just put the fat exactly like you see. That's what's going to go into the buttocks. But in this case, we're not doing a fat transfer, but I'm just giving you an example, right? That this even in this case, it's even more important, because why do I care if there's blood outlet, right? Well, I do care because I don't want her to have anemia. Our patients don't have anemia post-operatively. After surgery, they don't. So the patients don't have much pain because this tumescent anesthesia lasts for 48 hours, 2 days. So that's usually the most painful period, right? And so our patients don't have significant amount of pain, so they walk, and as they walk, they prevent a blood clot. The surgeon at the same time is protected. There is not going to be any sweating into the patient. The doctor is not very tired. I only do 1 or 2 cases at the most per day, usually just 1 case. And so I'm very, rested, right? I'm going to finish this before lunch. We have lunch, and, we're going to actually finish around 11 in the morning, right? And we started around, 9 or so? What time did we start? 9:24, so yeah, we're going to be done around 11, so it's very time efficient as well. And it avoids injuries to the surgeon. It avoids tendinitis, elbow pain, shoulder pain, and that sort of thing. Thank you.